Hello again, everybody. This is the last of the small lectures for which there will be a discussion question you'll need to answer. I'm going to post one after that on personality disorders, and I'd like you to watch that one. I think you'll find that one very interesting. Today we're going to talk about schizophrenia spectrum and related disorders, and we're going to cover first what's called a brief psychotic disorder. And it's brief because although it has very similar symptoms, the symptomatology is very similar to schizophrenia, it is really less than about a month. And really, unless you have a history from family or the patient themselves tell you that this has been going on a long, long time, you cannot conclude that this is schizophrenia. You would have to really first call it a brief psychotic reaction, and then at a month change it to what might be schizophrenia. There are a couple of other disorders that we won't cover that might account for that. But brief psychotic reaction has essentially the same symptoms, but for less time. Okay? So these are things like delusions, hallucinations, disorganized speech. So let me talk about delusions and hallucinations. My chair is going wompy. Okay, so delusions are false beliefs that are fixed and which do not become changed in spite of obvious evidence of it being false. And often what you'll see is that the delusion itself, which may or may not have any real grain of possibility of being true, but they're very much not true on the surface. Okay? So a delusion example, of which there are many kinds, could be that the television newscasters are talking to you. Okay? Or they know what you're thinking. Something like that. There are many kinds. Delusions of grandeur, delusions of all sorts of kinds. So hallucinations are different. Hallucinations are perceptual errors. So one or more of your senses, your five senses anyway, are distorted. And so the things that you see, hear, touch, taste, smell are not represented in the environment. So the most common kind of hallucination is an auditory hallucination. Less common are visual hallucinations, okay, and on down the line for the senses. Some of the hallucinations are the product of medical disorders. Hallucinations are easily produced using psychedelic drugs. So they are very different than delusions. When we say that there's a presence of delusions or hallucinations, what we're saying is that the person has a psychosis. That's an old word, and it's in opposition to the word neurosis. So psychosis means a loss of touch with reality in some way, either beliefs or perception. And the other term means that you have lost an ability to understand the way reality exists in some kind of obvious and gross manner. Delusions. Okay. So the brief psychotic reaction differs from schizophrenia in one other way, and that is that it often happens all of a sudden. It doesn't have a prodromal period, it's called, where it builds over time to produce this disorder. It's often very quickly seen. Recent stressful events, overwhelming stressors, are common, but not always present. Many people call this, people who are not in psychology or psychiatry or medicine, often call this things like a mental breakdown or an emotional breakdown or a nervous breakdown, something like that. Those are terms that are often applied to this condition. Okay, what do we do to treat it? Well, we give it antipsychotic medications in low dose and brief supportive psychotherapy and see what happens. And, this is tricky. If you give someone psychotropic medication, you're subsiding or removing the hallucinations. You probably won't get after the delusions if they're present. So is this, after a month, schizophrenia? Many times clinicians will call it schizophrenia to start with, and then if everything is gone in a month, they might reverse direction and call it a brief psychotic reaction. This is not real common, but it represents about 9% of cases of first onset psychosis, the first in that person's life, particularly if it's an older person. So schizophrenia peaks at about 16 to 20, something like that, in terms of prevalence, occurrence. And so if this person's 30 or 35, it's generally not going to be schizophrenia. All right. There are some risks in terms of temperament for this. So people who have other personality disorders, I shouldn't say other personality disorders, borderline personality disorder, schizotypal personality disorder in particular, a paranoid personality disorder, suspiciousness about life and people in general, and there's probably some genetic vulnerability, but it's not clear in what way that occurs. Okay, so let's talk about now schizophrenia. Schizophrenia is thought to be by some a group of disorders. In fact, in the last edition of the DSM, schizophrenia had several subtypes, and now we're looking at just listing the symptoms and calling it schizophrenia because there was so much overlap and so many difficult cases that couldn't be easily distinguished as one kind or another, and then there were catch-all category varieties, and it just wasn't working well. So it's been changed. And interestingly enough, lots of people have been schizophrenic. Bertrand Russell, Syd Barrett of Pink Floyd, Socrates maybe, John Nash, certainly the mathematician. Albert Einstein had some autistic but maybe some schizophrenic symptoms early on. And in fact, those two conditions can be confused. Isaac Newton had some kind of a psychotic break. Now, we don't want to use the term split mind. That's an old term that's very much misapplied to schizophrenia. So people with schizophrenia don't have split personalities, and this is not what used to be called multiple personality disorder, now called dissociative identity disorder. No. I have two videos of striking examples of people with schizophrenia. And they are different. One's male, one's female. Both are relatively young. And they display lots of symptoms that you can look at. So what are the symptoms of schizophrenia? Well, delusions, we talked about, hallucinations, disorganized speech. So the speech is not constructed in a way that makes sense always. And in fact, even their behavior can be disorganized. It can be very meaningless, aimless behaviors. They can have stereotypical movements. Okay, they could be even not moving at all, which we call catatonia, in which the person has waxy flexibility. You can move their arm in a position, but then it will stay there. This is about neurochemistry, of course. So they also have negative symptoms, which refer really to diminished emotional expression. Sometimes their emotions are very much inappropriate for a circumstance or completely absent when normally there should be some emotional response. You'll see a blunting of emotions often. And this all has to go on for at least 6 months to call it schizophrenia. And you have to rule out all the other stuff that could be psychosis or psychotic-like, severe major depressive disorder, bipolar disorder, schizoaffective disorder, which we haven't talked about, And again, autism sometimes. And it can't be caused by drugs or other medical conditions. So there are deficits for people with schizophrenia, from severe, in which the person is completely disabled and unable to function and must be hospitalized and be there, to down to can do some self-care, can exist with observation. It might live in a group home, to the person's responding well to medication and their symptoms have reduced and only occasionally come back once in a while, maybe need to get their medication adjusted, and maybe they can live at home in the right kinds of circumstances. All the way down to people who have one slightly prolonged episode and then it drifts away, particularly in the case of medication, and then it never comes back. They don't have another break. So there are lots of things that can happen. But when it's severe, you get disorganized speech, you get cognitive deficits in memory and attention and focus and verbal fluency and all those sorts of things. Delusions, hallucinations. They can't work. They can't function in interpersonal relationships. They can't take care of themselves. They don't have fun. They don't find enjoyment in things that they used to. There's a lot of withdrawal. In fact, when it's first occurring in the teenage years, that's one of the things you'll see is social withdrawal. They'll hole up in their room, and although brooding teenagers is a stereotype, it does occur, and one has to be careful about what that is. Yes, and they can also get other things, depression, anxiety. So here's what really is going on, because I'm saying it as if there's certainty, but we don't really know. Neurochemistry in the brain is changing, but that's because there's a disease process going forward if it is the kind of case where there's a progressive set of damages to the brain. So there's something about the neurochemistry that's changing in dopamine and other things. And other parts of the brain are being destroyed. If you look at on autopsy the brain or some imaging, you'll see over time, if it continues to progress, that the person actually has tissue destruction. Their ventricles become enlarged, for example, which is a way to see tissue loss. Okay, so prevalence for schizophrenia, well, it depends on the studies you read. Somewhere between 0.3 to 5%, all the way up to maybe closer to 1%. Average 0.6, 0.7%, something like that. In children, it's very rare. It's about 1 in 50,000 children. And at first, parents might think that the problems the child's having in terms of talking to imaginary friends, which is not uncommon, actually is a hallucination. There are more people in jail with schizophrenia than there are people in hospitals. And interestingly, almost 100% of people with schizophrenia that's chronic smoke. That's a brain chemistry teaser for you. Okay. Substance abuse is very high with this. Anxiety disorders, OCD, weight gain, sometimes associated with medication, sometimes not. High blood pressure and the things that come from weight gain. So we know this is genetically moderated because when you follow who is related to whom, the closer the relationship to someone who was schizophrenia raises the risk of that person that they're related to for developing schizophrenia. So if parents, first-order relatives, are first-degree relatives are schizophrenic, then the child then would have a fairly high rate, up to about 40% even, and in identical twins, the rate is almost 60%. But if it were purely genetic, it'd be 100%. So there are environmental moderations of this disease, and we don't know what they are. We've had a lot of new medications come on board, and that's been a great thing. So look for the discussion question. Bye.